So I see that everyone's quieted down, and it's almost 10 after. And I wanted to take a little bit of a moment to indulge in a story. I really hope that today, this being our sort of penultimate TR Talks for this school year, we can have a really interesting and engaging conversation that's also not a people on the stage talking at other people while others listen, but we actually engage and talk. So I want to open up by setting the stage, by talking about an experience that I had, I guess, 3-4 years ago now. It was late in the afternoon. I was pretty tired. It was probably around this time, maybe a month later. And I was asked to visit Baycrest because there was someone that wanted to talk to me about this program or the translation and research. And I remember sitting outside of Baycrest on a wooden picnic bench. The sun was slowly going down, and this person who had a degree in business and had been doing a bunch of different things for many years that actually around the various circles of Toronto said to me, you know, I am thinking of learning about translation because I am a patient advocate and I have been advocating for patients for several decades, but I can't access researchers. I need to learn to be more in tune with research because they don't take me seriously. I'm just a mom. I can't go anywhere. I'm just a mom. They only invite me to talk as a mom, not to participate, not to be at the table with everyone. And so I think I need to do a graduate degree to get more education, to be able to be a better voice for patients in our system. I found out about, 3-4 minutes ago, that Connie, who is the person I'm talking about, who graduated from our program last year, just started a new job. She is going to be coordinating and helping CAMH to engage patients in research and families. So not only is she doing something that she's passionate about, but she's helping to change the way that we look at health and wellness and the role that we play in research in our system. We are all, or will be at some point, patients, no matter what other hats we wear. We will all face illness or broken bones. And when we're there, when we're in hospitals, when we're in these institutions, if we don't have people talking for us, if we don't have them working the way that we would like to be treated, to treat others, then we become numbers, and I've seen it, and we become bodies as opposed to people. And so tonight's conversation, I'd like to welcome the panelists on stage, is very much about how do we as human beings, as individuals, as family members, as patients, as researchers, as professionals, as graduate students, as doctors, how do we make sure that we have the kind of system that will treat us the way we want to be treated? So I'd like to introduce Stacy, our moderator for this evening. Take it away.
Thanks for coming. I'm going to just pour everyone's water here. There you go. So maybe I'll just introduce myself and then allow the panelists to introduce themselves to start with. My name is Stacey. I'm a genetic counselor. I work at Sick Kids. I've been at Sick Kids for almost 20 years, working mostly with kids and families in the metabolic division, a lot of whom have now, in the last at least 10 years, have access to a lot of research opportunities. So primarily, my experience has really been with pediatric research and opportunities for families. So I'm delighted to moderate, and we're going to kind of wing this as we go and see how things work. And I'm excited to hear about our panelists.
Okay, so I'll start in. My name is Elise Maybe, and I've been involved as a patient partner in research for about 11 years. I've seen the good, the bad, and the ugly, if you will, and it's been a real eye-opener. I think one of the things, and I appreciate your program for this, one of the things that concerns me as a citizen is how much really wonderful research doesn't seem to go anywhere in this country. So one of my little pet things that I try and do is work to bridge the gap between research and the public in some way, and I think there needs to be a more systematic way of doing that. But I guess, in terms of my patient credentials, if you will, I'm really accident prone. I've had a lot of use of the acute care system over my life, starting with a near fatal car accident when I was 22. And recently I broke my left ankle running down an up escalator. So I've been in hospital fairly recently and had some interesting experiences talking about people being able to advocate. One of my roommates was somebody with a very rare metabolic disease, and she really had to fight to be heard from the bedside. And on the other hand, the nurses and the care providers were really very anxious to do the right thing, but they were trapped in a box where they ended up bumping their head against doing the wrong things, partly because of system issues and partly because they were not trained to really listen to her. And it was very difficult. She was so expert in her own disease. I suppose it didn't help that she looked really young and in fact was quite young. She was only 21. Anyway, so that's my story.
What about Pan?
Oh, do you want me to talk about PAN? Okay.
No, you throw it
Thank
out.
you.
Yeah.
My fellow PAN member. Okay, so the other thing is, as a patient and family advisor, patient partner in research, about 4 years ago now, a bunch of us got together and we said, we don't really know each other very well. All our relationships are with the organizations that invite us in and not with each other, and we have so much we could learn from each other. So a bunch of us, and it turned out to be a bunch of us across Canada, got together and said, we need to form some kind of a group where we can learn from each other. And that turned into the Patient Advisors Network, affectionately known as PAN by its acronym. My colleague here, Ron, is also a member of PAN, and many of us are. So it's brought the patient engagement movement, if you will, to another level, to have a community of practice for those of us who are doing this work, mostly on a voluntary basis, and who feel very strongly that not only patient partners in research, but in other aspects of the healthcare system can make a difference and are making a difference every day. So that's that story.
Good afternoon, good evening, everyone. I'm Ron Boleno. I am a mentor here in the TRP program. For the first year students, I haven't been as involved with the first year crowd, but those that are in their second year finishing up, they know me. Roger smiling there and a few others. I always start off saying that we tell stories. Okay, that's how we start off. And my story was that I was a caregiver to my dad that had Alzheimer's. My dad had Alzheimer's for over 10 years, passed away in 2018, okay? And I've only been involved in this community since 2015. Okay, so not as long as Elise. With patient engagement, I've only been involved, I think, only 3 years. But with my dad's story, we were dealing with a lot of pain points. Okay, so in our lives, as a caregiver to my dad, he was dealing with some challenges, and my mother was dealing with challenges, and I had to support with those challenges. And that's where I shifted, okay, at one point, and I think the first time was actually when I met Rich Fody here, who happens to be standing up at this perfect moment, okay? Okay. So with that, Rich met me at my very first presentation with the Alzheimer's Society of Ontario. I led an event, a full-day event. I was just telling my stories of people that go missing, people at risk that get lost. That was one of our challenges. And what happened was that Rich met me, and I came and got involved with the TRP program. During that time, I became a co-chair with AgeWell. AgeWell's National Center of Excellence, which some of you know. I'm the co-chair for the Older Adult and Caregiver Advisory Committee. I'm also involved with a few other groups, Baycrest, the Center for Aging and Brain Health Innovation. I'm on the Seniors Advisory Panel, and proud to say out of the 16 of us, I'm the only non-senior on that panel. Everyone is officially a senior. I do a lot of work with police. But with the research community, it's only been in the past maybe 2 years that I really got quite involved. There came a point where as a lived experience, whatever word we use, okay, so I'm not picking on the words. Some people will get triggered on the words, okay, patient, caregiver, lived experience, whatever that word is. For us, for me, that didn't really matter. I was just more concerned that there came a point, Elise, that I think we switch and we become advocates, okay? That it's no longer just about our story, it's about, and Connie, you'll relate to this, right? Okay, you kind of see some things where, okay, we could get better at this, okay? And who do we need to speak to, okay? As that person you met, which was Connie, okay? How do we improve the system so our voices become a little bit louder? And then we realized research is a big place where we could be major players. So that's where I kind of got involved, not just as a participant, but eventually as a collaborator, and I've even led some research projects from some of my innovations and ideas. Another person sitting here in the front row is my good friend Paul Lee. Okay, so Paul Lee was just coming here as a guest, but Paul is a good friend of mine, an older adult who, Paul, I can share, just briefly? Yeah, so Paul's living with dementia and Alzheimer's. So he's out there advocating. We recently just got on a research project together on CBD oil and people with dementia at home. So that is with nurse Charlene Chu at the University of Toronto. That's one of our research projects. And I think we have a couple more that we got funded for. But anyways, that's just a little background about myself. One group that I am quite involved with is over in Laval, the Patient Engagement Resource Center over there. And we're doing some work around scaling up patient engagement across Canada. So that's one of my other projects going on. So that's me.
Great, thank you. I'm wondering, I guess I have many questions. I guess for me, it's the first time I've heard about PAN, and maybe could you comment about how PAN specifically is helping to advocate for patient access to research?
Well, that's a good question. First of all, PAN is a community of practice and doesn't advocate other than to be involved. Okay. However, individual members on our discussion board have talked about that, and is it the CMAJ who's just opened up? Or was it the BMJ? I forget. One of the major journals has just made the paywall go away. So it means that patients now can access research more readily, at least from that journal. And it has been an uphill battle because we'll get sent links when you're on a project by researchers. Oh, read this paper, read that paper, and you go and then boom, you hit the paywall and you can't get at it. And so all of a sudden you are not on an equal footing with your partners on the project because you can't access the same information they can. So I'm delighted that there seems to be an active movement afoot to lower those paywalls and get rid of them, especially since a lot of this is funded publicly, so it should not be hidden from the public.
Are there some things that are working well in patients connecting with research and some things that are not working so well?
So from my perspective is that we're getting at the table. That's kind of the key, and that's not just as patients. Mentoring the TRP students, I actually challenge you, how do you get to the table? Okay, that is something that is really important. Whether that pays off or not, it's just about getting to the table. From the community that I'm working with, the aging population, older adults, caregivers, we are getting to the table now. It's a question of what happens at that table. Is it just going to be, that T word, the tokenism piece? Are we just there just so that you can check it off the list and say, okay, we do have a patient here or a caregiver? No, it's actually, for some, it is just checking it off the list, but we are getting to the table now. I really believe that there is a shift in the research community of how do we work with patients, okay? One of the challenges, for example, last week, Mel as well from CAMH was there. Connie and Mel are the researchers doing work on engaging patient. Mel, you were at the CCNA event, the Canadian Consortium on Neurodegeneration on Aging, and it was about patient engagement. And one of the things I brought up in my presentation was something as simple as remuneration, okay? Or the ability that, okay, we're at the table, but is it fair, okay? So that's a challenge. Is it fair that I would say, don't count the students here, but in a room where we might be in, there might be 10, 20 of us, and I sometimes put my hand up and say, by the way, who here is not getting paid for being here? Chances are it's the one that they're always asking the question from, okay, the patients or the caregivers. So that piece of how do we support them from parking to travel to even having them there paying for their time is probably the area that I think a lot of researchers are trying to support. But that is a challenge still. But we're getting to the table, so that's a positive thing.
So I would say it's been, 6 years now since we've had the SPORE program, Strategy for Patient-Oriented Research, out of CIHR. And the good news is that put patient engagement and research on the table, and there is nothing they will fund that doesn't have a patient at the table, even if we're a tick box. So that's the good news. The bad news is that it hasn't really supported the whole movement equally and strongly in the way that it could. They're going through a renewal right now for their funding, and I'm hoping that with that they'll get sort of to the point where they can do the 2.0 version of it and get better at it. I'm just trying to think of what else I want to say about that. I've been a trainer for the SPORE curriculum that they had, and even that curriculum, even though there were some patient partners who helped develop it, it was really done from the researcher point of view. How can you help us do our research? And it wasn't really thought of as to why would a patient partner want to be involved in research and what can they contribute. And so I think there's more that needs to happen in that area. I mean, why do any of us get involved? What are our motivations to get involved? I think in some cases, there's research that relates to a chronic condition that we might have. So there's an obvious personal interest and expertise, I might add. But for myself to be involved in research, I'm interested in system change, and so the research I get involved in is not usually disease-based, it's usually around system issues. And I want to make a difference. That's why I get involved. And it seems to me that a lot of researchers do their research because they want to make a difference. So we have that in common. And I think that's something to be borne in mind. The other point I want to pick up on is something Joseph said in the beginning when he talked about what we bring to the table. It's not just I'm a patient. It's not just that I've had experiences in the system, but I used to design software for a living, and so I have all that analytic background. I bring that to bear in the research things that I do as well. And I have other colleagues, and we're not just little slices. This is the one role that we play as the role of a patient. We are actually full human beings who have all these other things that we do and that we know, as you all are as well. You're not just students. You're not just students. You're all kinds of other things. So everything you experience in life, you bring to the table when you sit there and do research and get involved in research. And so I think that's something that when you engage with patient partners in research, you need to bear in mind and probe a bit and see what people are actually bringing to the table and why they want to do that particular project with you.
So I just wanted to add, I don't know, she said that the question that I think you guys hear a lot here in TRP is the why question. That must have come from Joseph or Rich one time or twice or 100 times. So the why is a big deal, right? For us, like right now, Connie, Mel, you've invited me to come work with you guys, right? Yeah, we're gonna have the why conversation when we sit down in a few days, right? Why is Ron willing to commit his time? Why is Elise willing to commit her time? So there is a why piece, and as well from your end, you have to understand your why. But there is this thing I like to talk about, is the return on. So what's the return on investment, the return on time, return on us giving our stories. In our stories is where you're gonna find the data you need, okay? So that's what you're trying to pull out of it. So all these things around the return on, you're gonna find some of your whys there, okay? So why, what are you getting out of it? For me, sometimes it's a pain point. Okay, the pain point that I know a lot of other people that are going to be dealing with dementia and Alzheimer's and caregivers is that how can I reduce that for them? Okay, and it's also the pleasure points. I know what some of them may want: social inclusion. They want to have a higher quality of life, a return on quality of life. So those are some of my whys. So just because you threw up the whys, I wanted to make sure they heard some of the whys out there. So.
Well, if I can just add, one of my whys is system change, and certainly in Ontario, we're right deep in up to our necks in it. So it's a very exciting time with a lot of opportunity and a ton of pitfalls. So I'm thrilled to be involved, to be honest.
It's an exciting time. And I don't know if we should ask if the audience has any. I mean, I can keep going, but in case anyone wants to, exactly, yeah, perfect.
So I'm a TRP student, and I'm also an early career clinician researcher. I started about 6 months ago, and so I'm just starting to develop my research program, and I'm really interested in involving patient partners, even just in sort of designing the methodology and figuring out how I want to do my research. And I've had some trouble connecting with patient advocacy groups. So can you speak a little bit to how, like give some advice to how to get patient partners involved?
So there are a number of ways. This is not a really easy answer. I would love to say you could talk to OSU, the SPOR support unit for Ontario, and they have a whole list for you. You could try that, but they don't exactly have a list, but they do know people, so you could try them. You'll find patient partners in any hospital, some of whom may be interested in also being involved in research. So that would be another venue, if you will. If you're dealing with research that deals with specific communities, going to those communities, actually getting to know people at the community centers and so on, developing relationships that way is a good way. And I really applaud you for starting early with this. In my opinion, the best patient partner experiences I've had is based on developing strong, trusted relationships with the principal investigator and the team. And I'm very pleased to say I have had that. I remember one of my very first experiences was with a very exuberant stem cell researcher in Ottawa. And she said, I'd love to have you on my project, and can I take you to dinner? And we had the greatest dinner, and over wine we got to know each other. And we explored what we could do for each other in terms of the research. So that's one way. Make sure you have a good coffee budget.
Can I ask what your research is on? Or, yeah.
Yeah, so it's with patients with spinal cord injury.
Oh, okay. So first, congratulations on being an early career researcher there. I work with a fair bit of those researchers. One challenge for you, sometimes you're not in the power position to control the budget. Okay, sometimes you are, but sometimes it's someone above you, and you're not going to agree with them. So my ask down the road is you do shift that mentality. There's some that I'm not a fan of personally, of how they approach it. Okay, so for me, I'm a big fan of connecting. Okay, so connecting the dots. A lot of people know me on that piece. It's not something that should be cold. I really believe exactly what Elise said is developing relationships, and that's for you to get at the table with us. Okay, to find who are the leaders out there, who are, it may not be me, but I could lead you to someone else. One thing I do, for those that follow me on Twitter, RB33 Canada, just plugging that right now, you'll see hashtag breaking bread. Okay, so you have a coffee budget. I want meals, okay, out of it. I want to sit down, let's upgrade it to a meal, have a 1 or 2 hour meal, and then with those, okay, who you could leverage, okay, in return, okay. So it's saying, coming to Lisa or me, say, Ron, who can I connect with that you know? Okay, so you have to know what you want. Okay, and say, I'm looking for this type of participant or partner. And just by the term partner, okay, it's not cold. It's supposed to be something that's somewhat equal or a relation. So partnerships, you need to create that relationship. And that may not happen right away, but showing up, okay, acknowledging them. Again, I throw out social media as one example. You're gonna find a lot of patient partners on social media, okay? Reach out to them, so that's a big piece. It's developing that skill that you're not gonna get in a classroom, okay? It's about going out there, having meals, not just talking directly about the research, but it's getting to know us as well, okay? Getting to know our lives, getting to know what's going on, why are we there, all those questions. But I'm a fan of the social piece. Okay, so it's actually having meals. If you can get 2 or 3 of them at one time, okay, great. It doesn't have to be in person, it could be online. Okay, so I have things where I have meals with people online, okay, with researchers online. And there's a researcher I want to know in another part of Canada, and I just follow them, I reach out to them saying, I'm interested in your work. Can we, have a little coffee or something online? Or if you're in town, let's meet up. Okay, so that's just one way, but there are other ways as well.
Hi, I'm a first-year TRP student, and effective communication is such an important thing for patient advocates to get other people to really feel empathetic towards the situation and spread the cause. So my question is, what communication techniques or strategies do you use in order to communicate effectively and make people feel for your cause?
Ooh, I love this question. Thank you. Do you mind if I go first? Yeah, no. Sorry, it just got me excited. One of the things I've experienced, so I used to be in the tech industry, and I developed very complex CRM systems for financial services with a global team of 6,000 to 8,000 people. The only thing that made that possible when it was one code base was to have incredible project management. And the one thing I've really experienced in the healthcare world is a lamentable level of project management expertise. If it's good project management, it's rare. And so to cycle back to your comment about communication, communication is built into good project management. When we were in our teams that were global, we had regular scheduled communication pieces. We had regular minuscule little reports that had to go by. If we hit a problem or a stumbling block, we had regular meetings to overcome them. And we had to develop our relationships with people very often just by phone. And so communication is absolutely critical, but you help yourself a great deal if you actually have a plan for communications. Even if your monthly little email says, we didn't do anything this month or nothing new to report this month, it is a reach out to people so that they know. One of the things I find distressing is I sign on for a 3 or 5 year research project, and there's a lot of activity in the beginning, and then all of a sudden, nothing. It's like the dead zone, and the dead zone can go for 18 months. So I'm sitting there thinking as a patient partner, am I still on this project? Do they even know I exist? What's going on? And if I reach out, they say, oh, well, we're just gathering data, so there's nothing to report. Well, tell me there's nothing to report. So I hope that in some way addresses part of what you're asking in terms of communication. Jeff?
Yeah, I'm actually going to go just in general and some tips and tricks that I use. Okay, so this is not just with patients, this is in general for networking. One, I will always say, I'll go through maybe 3 or 4 here. A business card. How many people don't realize the power of having a stack of business cards in one pocket, right pocket usually, and ready to give it out to someone, and then put their business card in your left pocket. Okay, something as simple as that. For every 10 to 20 business cards, I'm going to get nothing out of that there. Okay, but I just need one that pays off really well. Okay, that's one form of communication in that piece. Social media, okay, I mentioned that earlier. Touch points of social media, just simply liking someone, okay, or liking one of their tweets, okay, I'll say, oh, I forgot about this person, and that reminds me, okay, of who you are, okay, and the work you're doing. Those are minor little things, but those are great ways of little touch points to say, hey, I saw what you tweeted, I support that, or I like it, or I'm paying attention, let's say. Okay? Another thing that I would say is, again, I actually research ahead of time the researchers. Okay, that's me as a patient. I research the TRP students. Half of you I won't remember right now, but I've read all your profiles ahead of time. Okay, what do you do for us? Are you researching us ahead of time to know that, well, maybe somewhere in my tweet, Ron played pickleball, a year or two ago. Okay, that I'm out there breaking bread. That that's what I'm interested in. So, getting all those key points ahead of time about someone else will help you when you interact with them. You kind of things are softened up. Let's say in that communication piece. And the other thing is learning how to come up with powerful questions. Okay, sometimes the questions that are asked, I've had people, so Ron, tell me what your challenges are. Well, I have to do a lot of work here. Okay, versus, can you tell me your challenges related to your dad when he was at home and he was at risk of trying to leave the house? Okay, or something, get a little more specific, and then you kind of can help me focus. But you know ahead of time that you've researched Ron, that, okay, he does work in this space. So that's a topic he's very well versed in. So that's some stuff that I'm going to suggest, like preparing ahead of time before you interact with the person.
Great point.
Thank
I
you.
just wanted to add another aspect of communication. We've talked a lot about KT, and you're in the business of that to some extent.
Knowledge translation.
Yes.
Because I know a lot of people don't like acronyms, right? So the
Sorry,
acronym is a challenge.
I'm sorry. May I
KT,
come-
yeah.
Yes, knowledge translation. So that's a very sort of formal, somewhat scientific approach to communications. But there is another that comes sort of more from, if you will, the corporate world, which is marketing and communications. And since one of the reasons I got involved in research was also to make the connection between research and the public, I feel sometimes research tends to be hermetically sealed, and the communication is within the community, but not reaching out to the public. And I would urge you all to think at the beginning of a research project to develop not only your internal communications plan, but your external communications plan, particularly if your research will hopefully dramatically affect people in the public domain, so that you can start out and say, we're so excited we have just received a grant to do X. You go on Twitter and you let the world know that. And then as your research progresses, you can continue to have that conversation. And you don't know who comes out of the woodwork to help support it and to help make that research translate to benefit in the public domain by being implemented. You can enlist the public through a good communications program. At least that's my thinking on it.
Just wanted to add one more thing. You brought up KT, knowledge translation. I came for the KT class here. I know some of you were there in Raza and Chris's class. The first slide I put up was the word caregiver, and I talked about words. Okay, our words are not the same words to some of you. Okay, so caregiver, I threw up caregiver, care partner. Outside of North America, it's carer. Okay, mom, dad. You don't know exactly what word I use, and that's part of your job to kind of help us through that. Okay, if we're there, we throw out KT naturally because we're in this group here. But outside of this, the patients have no idea what KT means. Okay, even when they hear the word TRP, I don't know what all your definitions and what your one or two sentences are when you talk about the TRP program. I think it's different for all of you, but pretty much the same, but some of us won't know. What's translational research? Explain that to me in 2 sentences, right? So you're gonna have to come to us, okay? And not force your communication on us, but kind of help us understand yours as well. That's a tricky thing.
I have a funny little story about that. When I first got involved in research, somebody said, oh, so-and-so's the PI. And right away I thought of Magnum PI.
Private investigator.
Yeah, private investigators. I had no idea what it was until somebody explained to me after a while. So yeah, it's really important. Those of us who come outside, every industry or endeavor has its own jargon, and research has plenty of it. And I could scare you to death if I started to talk in tech jargon, but I won't do that here. So I know, because I used to go home and talk to my husband, how off-putting it is when you talk jargon.
Anybody? Yeah.
Thank you so much for sharing. This is a really interesting talk, and I'm really excited to hear more of your perspectives. Patients as partners and like patient-centered care have become kind of like buzzwords, I feel like, in the past couple of years. And for me, working in the clinical setting, I feel like sometimes it's not always genuine, and it's sometimes hard to see how a patient would direct their own care in that environment. And I worry that research has that same potential. So how, you've touched on it a little bit, but can you elaborate more on like, how do we make sure involving patients is genuine and authentic and not just tokenistic like you spoke about?
Okay. So even that word, I tweeted out patient-centered care, and the researcher I was working with, she actually works on person-centered care. So she quietly says, "Thanks for having a meal on person-centered care." And I said, "Oh yes, person-centered care." Even I was. There's no perfect solution of how to do it. From our end, we'll know when it's ingenuine. Okay, we'll feel it. It's a lot of feeling piece. Okay, that's how I would assess whether I, feel that, okay, do I trust? Do I feel confident that this is honestly a patient-centered care, relationship that's happening there? Again, it comes back to, I think a big part is the words. Okay, understanding the words, body language, how you communicate. Okay, if you're really just saying it quickly, if it's poor bedside manner, okay, we'll feel that. Okay, those pauses, those moments where it's a healthy pause when you just look at me or acknowledge me. Okay, acknowledgement is huge. Okay, not like a yup versus yes, I get you, Ron. And repeating, okay, maybe what you interpreted, and I can say, yes, that's exactly what I'm talking about. Or, no, it's a little bit off like this. That's actually a great way to communicate, to say, okay, you're hearing what I'm saying, but even if you weren't hearing it properly or you interpret it differently, that's one way of communicating that if you repeat to me or try and explain to me how you've interpreted, that I would believe a lot more. So that's one technique.
Well, I think Ron's pretty much said it all. I will say that there is a trend more to use the terms person-centered rather than patient-centered. And I was in Leeds last year at a symposium, and the keynote talked about person-centered versus patient-centered and made a real case for person-centered as opposed to patient-centered, because we are actually whole people. Patient is a role, it is not a person. So I think that makes it convinced me that I wanted to use the term person-centered at any rate. I don't think I have anything more to add to that.
Yeah, go for it.
Hi there. So you guys are actually touching on really important points here when it comes to communication. I'm a doctor, a patient, as well as a researcher. And I've literally sat in rooms with people that involve patients on one end of the table and researchers on the other end of the table, and doctors there as well. And everybody seems to be understanding what the conversation is about, and then I approach all of these people independently after the meeting, and everybody understood something different. Because we don't have a common language in this area where patients are learning how to speak with researchers, where patients are learning how to speak with doctors. And even on the medical side, I think researchers have a hard time in learning how to communicate with patients. A wise patient advocate friend of mine used to say that I think researchers overestimate the vocabulary of patients, but they underestimate their intelligence. And I think that's what's happening when it comes to this communication that's happening at the table. But that's an aside. I wanted to ask Stacy kind of what her experience has been in this, not just trying to bring patients into your own research and your own kind of clinical role, but how do you do that also when kids are involved, and how do you make sure that kids have a voice? How do you make sure that the voice of the family as a whole also gets heard? Because that's a messy space to live in and to try to do research in.
Yeah, very good point. So I'm a genetic counselor, so that puts me a little bit to the side. But your point about being in a room with a physician and a researcher and a family is very poignant, particularly when the physician is the same person as the researcher who's taking care of the child, right? So there's potential bias and or a perception of coercion, right? In the context of, this is my child's physician, I want to do anything to please and or protect my child. Would I be unwillingly going to say yes to research because of the relationship we have? So within pediatrics, there's specific guidelines put out by the Research Ethics Board, and certainly the clinician can't consent their own patient to the research. It's got to be done by a third person. And I certainly have been in that role before, in consenting someone and ensuring, at least trying to ensure that they are aware that their clinical care is not dependent on their decision. But you can say it overtly, but I'm not convinced that certainly people feel coercion in that regard, for sure. So that's one piece, and then the other piece about the parent making decisions for their child, and I think that might go into scenarios with other types of medicine, and maybe in the dementia field, or where there's the individual, the participant cannot consent on their own, right? So certainly in pediatrics, we do try to obtain assent from children in the context of if they're intellectually capable of providing at least some general acceptance to the research, which I think is a very important part of pediatrics, to ensure that young children, I think they use it between 7 and 12, let's say, that they do have a say and they can say no. And that certainly would be a discussion with the children and with the parents themselves. I do find, and I think this is one of my questions maybe for the rest of the panel, is the idea of, in a desperate situation, so when you're medically fragile and have no other options, are you more susceptible to say yes to certain types of research as a hopeful gesture? And I know in my field, I was recently at a big parent conference where a lot of pharmaceutical interest is being done, particularly related to gene therapy. And the idea for some of the families is, if they participate in the first trial, they may be ineligible for the next trial. So it puts a lot of burden on families to try to make the right decision for a child that might have a progressive condition, and what research is going to be the best option. And so I guess to turn my question over, is the idea of vulnerable populations and or individuals who can't consent on their own, and how do we best engage the patient or the partner as a partner, as opposed to, and try to level that playing field a little bit.
So I'd just like to sort of clarify something. There is a vast difference between being a patient partner in research and being a patient participant in research, right? So as a patient partner, you aren't representing anything. You are there to help. In some ways, you might be helping define how you reach out to the participants and help discuss what some of these issues are that you've so rightly raised. As a participant, if research, that's a whole other ball of wax. Yeah.
Just my view with regards to making those decisions. I'm glad you used the word better, best. Okay, I'm not a fan of right or wrong. It's not black or white for me. I don't know what's going to be right or what's going to be wrong. It's if I'm going to make a decision or a choice to be involved, I actually ask a very simple question for a researcher: so what? The so what question. What's the big deal with your research? Is it going to create an impact to my world or to the community that I'm supporting. Okay? Research many times takes not 1 year, it takes maybe 10 to 15 to 17 years. I don't know what that number is anymore now, before it actually makes it out there. Canada's known for pilot projects, pilot research. So I think it was in the past over 90% was just researched and then filed away. I'm at the point where for my life, it's about will it create impact? And I'm a patient person, okay? And I'm saying patience, like I can say, okay, if I'm doing this now and it'll pay off maybe 5 to 8 years, that to me is fine, but I need to see that. You need to share with me the so what piece. What's in it for me now, and what's in it for me after possibly the research is done. It may not happen, but it is, like your work may be a failure, okay, and I have an acronym for failure. Some of you saw that. It's healthy to talk about failure. My acronym is find another important lesson, okay, when you fail. Okay, and a lot of research has failed. I don't know if we've learned the lessons in some of them, because some of them are repeated again, okay? I'm saying, so what? Why are we doing some common sense research already when I'm more interested in the impact? So that's my value system, that's what I care for. So I have to do that calculating piece. Can I see the so what piece? And it's on you to actually develop the skills. Not just this, I know we're talking about researchers, but this is also innovators. I'm in the innovation space there. So you gotta be able to sell your work and share it and say, this is what we're doing, this is what the return is, hopefully down the road. This is how it applies to you or your community, Ron, so. Yeah.
So I think these are really important questions also because the research to implementation cycle is, I believe, 17 years. The world is changing so rapidly, particularly in healthcare, because we're going through a massive paradigm shift. We're going to have the Uberization of healthcare if we're not careful, and it's going to happen in a blink of an eye. It will outrun the research cycle. So we need to make sure that we do research faster, more efficiently, and get to implementation much more quickly. Otherwise, you're going to be working on something that'll be obsolete by the time you're done. And I think that could be hugely disappointing and a total waste of everybody's time and talents. So, and unlike Ron, I'm hugely impatient, and I think that's a function of the fact that I'm much, much older. I am definitely a senior and have been for some time. So I want to see things happen yesterday. Okay, I think that's all I really want to say.
Paul, you wanted to say something?
Can I talk now?
Yeah, go ahead, Paul.
Okay. I just want to say thank you as a patient, as a person living with dementia. I come across different doctors and researchers, and I'm like, sorry, what'd you say? Really? Why didn't you say that before? I appreciate your candor about that. I just wanted to say that.
I just wanted to weigh in and get back to the question that came in about childhood disability research, or how do you engage children, and I think that you clarified it in the sense that there's a very big difference between partners and participants. So my background is really, I have a lot of experience as a parent partner in research, and so that my experiences are in the neurodevelopmental and autism research world. That's where I come from. And I wanted to say that now there is movement in the neurodevelopmental research world to engage children as partners in research, so that, and all the things that come with it, the ethical discussions about how you do that, the consent, or I know you were talking about in terms of assent and partnership, in participation, but that is now starting to happen. But it is a process, and I think Ron said something about it before, that the process of engaging parents or caregivers of children within neurodevelopmental conditions is about their why and why they're there. And I think that, Ron, you said it really well, that understanding the why they're there and why they want to be involved and what involvement means. And that, as we know and as you're learning in first year and second year, which I went through in the TRP, you know that there's a research process, there's a cycle, there's also a translational design that you're all learning, which is the person at the center. And that's something that I would say really adds to this discussion. And that in the TRP program, we learn research design that's person-centered. So it's going and advocating for the design of research to take a translational design so that you can then you can begin with your needs analysis, which you've all learned. You can bring it together because you can look at the needs analysis and then you can start to include the voice of the person with lived experience right at the beginning of the design phase of as you're creating your research. So I wanted to answer that question, that in terms of involving children in research, it's starting to happen. So anyway.
I've read up on that there, Connie, as well. The why, coming back to that as well, I also believe another powerful question is the why not. Okay, I don't know if that's been asked. Sometimes I like the opposite. If you can understand the why would we not be involved, okay, there's learnings in that piece as well. Okay, why, maybe it's not Ron that you need. Ron may not be the lowest hanging fruit, okay, that you're gonna access, okay? There's another patient partner, another caregiver, okay? So don't put us all in one boat that if Ron says no to this, that means that this is not worth it. I always believe you need to, talk to a few more, okay? Doesn't mean that Ron knows everything. I always tell people, challenge me or do not even agree with me. Find someone else that might give you another answer and what is their why that's different than Ron's, okay? So I also like throwing out why not. I don't know if that's something you guys discuss, but, think about the why not as well.
Anybody else? Yep, go for it.
Yeah, I just wanted to speak more about the tokenism concept that you brought up. I think patient as partners is new in our culture, and it's going through multiple iterations, and lots of things are happening, and we as patients, as clinicians, as administrators have a shared responsibility to guide this culture in a meaningful direction. So at my hospital, we have patient partners in everything that we do, our senior leadership board meetings, but I find often when the patient is brought in, they're put on a pedestal, and everything that they say is gold, and it's never ever challenged. And in fact, as a clinician, you are kind of worrisome to challenge, but I think that challenging and that discussion is where great ideas are generated. So how do I, as a clinician, help change that culture so we have a more genuine and meaningful interaction with patients as people and not God, right? Like, they're people and we're all the same. Yeah.
Sorry, I really like this question because I've been on the receiving end of what I call pedestalitis. And, oh, it's so wonderful that you could be here. You just said the most marvelous things. And I'm thinking, really? This is just a thing I said. And if it contributed, great. But the adulation is false. And it comes from a good place because people are indeed grateful sometimes if you spend the time, etc. But it's also an incredible indicator of a power imbalance, of a lack of partnership when people feel that way. I much prefer to sit around the table where people will say, oh, well, that idea you had, I don't think that's going to wash here, but we can take this piece of it and we can do that, where you actually have an even meeting of the minds. I'm not sure exactly how you get there, but again, it's the trusted relationships and the attitude of not seeing the patient as an other. Because when you put them on a pedestal, you're seeing them as an other. Oh, the orangutan has arrived. Let's hear what they have to say. Let's see them go through their little paces. And that happens all too frequently, I think, particularly if it's somebody who has sort of noticeable physical issues or mental issues or whatever. So I remember dealing with somebody at one point who was fairly severely disabled and in a wheelchair, and she was a patient partner, and she was going to take on this project. and she didn't reply to emails and didn't turn up at meetings. So I got in touch with her and I said, you know, you really need to, and I understand if you're not well, but you need to at least run the flag up the pole and say, I'm sorry, I'm sick, I can't come. And after the third time that this happened, I reamed her out. And I think it was the very first time in her life she'd been reamed out for anything, because people don't dare. And we need to treat people like humans. I felt, you know, I was treating her like a human. I had expectations of her I'd have of anybody, given the limitations that she had. So it's really attitudinal. You're not dealing with some other, you're dealing with a person, and you deal with them as you would anybody, a colleague, given that you have to modify sometimes for the fact that people have come with different knowledge and experience to the table.
My thoughts on this with regards to the power dynamic. I'm not a fan of putting us at this high level, you know. Challenge us, but it's how you communicate with us, okay? That communication piece. It's one where I've realized I've been at many tables and they try and get my blessing, you know, like, Ron, can you bless this? You know, and then we can move forward. I said, no, it's like, let's discuss it. Do we understand? Do we agree with this together? Okay, but tell me what's not working for you. Now, that works for me, okay, at this point. Some are still new. Some are even too shy, and they're not even comfortable being put on this pedestal. They're not, you know, like, everyone's eyes is on this one patient or caregiver, whoever it is, and it's like they're still learning. So we're at different levels. You got to also remember we're coming at different stages, different degrees of expertise. You got two up here that's seasoned, but there are a lot that are not as seasoned as us. Seasoned being like salt and pepper, you know, like, yeah.
Thank you.
You know, people like seasoned. Okay, and but I really say take advantage of those side moments. You just said it there. You said it earlier. It's when the doctors, you know, are all in this one room, but it's when you went outside the room, okay, and you had those casual conversations. That to me is what I love. It's those moments is where you get probably more of the golden nuggets, okay? It's those little side conversations where we build up the trust. Here it's formal, casually formal, sort of, right? But in the end, it's take advantage when you're outside, when we're relaxing, okay? That's where you build up that trust, that relationship, and you hear the honesty many times. So that's just one way I'm going to suggest is if you can take advantage or create those moments, okay? Hey, let's go have a coffee or during the lunch breaks, okay? Sit down with the patient. Don't sit with the doctors, okay? Have a sit down with them and say, how do you think it's going, right? That's where you get those great opportunities. You know, you might have to go through an hour presentation and all that, whereas that 5 minutes of sitting down, you know, and I'm putting salad in my mouth is when I'm going to tell you honestly, or you're going to tell me honestly what's going on. Okay, so just some ideas there.
I was just going to comment on your question about how in my hospital it seems like the most effective ones are where we have more than one patient around the table, but feasibility usually comes into that. It's hard to find motivated people. It's surprisingly hard to find patients that want to get engaged and be research partners. I'm not talking about participants in research, but engaging in this way. And the people that do usually have some sort of motivation or agenda. When I've been involved with workshops, proposals for research, organizational restructuring, where we've had more than one patient voice around the table, it's been much more effective. And then it avoids that pedestalitis that you were talking about. So that's a suggestion on how it's hard to make it happen.
Yeah, I think that's actually excellent. One rule of thumb we have is there should be a minimum of 2 patients, and there's some practical reasons for that as well. We are, after all, patients or caregivers, and sometimes we can't make it. I've just signed up for, gosh, I don't know why I did this, a 7-year research project, and I'm thinking, am I even going to be around in 7 years? Hopefully, but you know, it's quite a commitment, and even 3 years is quite a commitment. The 3-year research project I signed up for about 11 years ago, no, 10 years ago, is still going strong, actually, in its sort of aftermath with the publications and, you know, the KT part of it, et cetera, et cetera. So I think a lot of us are, research is kind of like this black box. You don't, a member of the public doesn't know what goes on in research. It's this sort of weird other thing. It's like being an astronaut what the heck do they actually do? So it's very scary, and I think that's one of the reasons why we don't naturally jump to get involved maybe. And it's all the more reason why I'll go back to the comments I made about communication. We need to engage the public in communication about research so it is no longer a black box, so the value is seen, so that we have more people who would like to sign up and be part of it. But definitely two, because I can happily disagree with a patient partner around a table and have done, and that gives a richness to the discussion in the same way that two researchers might disagree with each other.
Well, I don't agree with anything you just said. No, just to go. We have a role on our part. It's not all on you there as well. Okay.
Yeah.
So as I mentioned earlier, patients are at different stages, and part of that is bringing up patient trainees as well. It's also good to have not to like a Ron and Elise together. Okay, separating us sometimes. So we have a role, but can you support us? Okay, there are some hospitals that I know that are much better than others, okay? And we would gravitate to that. Can you showcase us sometimes? Okay, sometimes put us out there if need be to say, okay, this is an example of a patient partner working with us. There was one that was tweeted out recently that someone got upset with, where a patient partner, just because they were being funded to be on that team, okay, $25 for their time and per hour, that someone from the review board says they shouldn't be on the final report or something of that nature because they're getting paid, right? It's not, they shouldn't be. Whereas that's their time, okay? I'm on the view, and I'm sure you are in the view that no, they should be as one of the co-authors on that report, even though they're getting paid, okay? So there's still a mindset that needs to be changed, but we gravitate towards the ones that we know, you know what? You're supporting patients. We see how you support them. We will share that as well if you help us share it, okay? Set us up as a team, okay? This is not one or the other. We are a team here to succeed. So do we tweet it out together? Do we tell a story? Are we at a conference together with you up there on stage, okay? We do that a lot with AgeWell, okay? At this point with AgeWell, every project has to involve, you know, a few older adults, a few caregivers. That's something that we pushed for, okay? So that's just something that we have a role here, but can you support us with that in sharing our story together, okay?
I think Ron's right about us having a role, and it's one of the things we try and do through PAN. We have a private community discussion board, and very often the topics relate to things like tokenism and compensation. And across Canada, those of us who do this are saying, you know, oh, gee, I want to get involved in research. How do I do that? And we help them out, those of us who are more involved. And, oh, I've run into this situation. Is this tokenism? Help me understand it. What do I do? Do I leave in anger? Do I just refuse to turn up? Do I say something? What do I do? And so we're trying to teach each other or support each other within the context of our community. But as far as I know, we're the only group that does that. Other than just very, very informally, and that happens for sure.
Sorry, something that Ron just mentioned before, and Elise, actually for all of you, this is a question. So you said in AgeWell, you have to try to include as many older adults as you can and all that. For our students especially, we always tell them you have to, you know, before you start digging into research, you should really try and verify that what you're talking about is real. So you should go out and talk to people who are being affected by this and understand their point of view just informally. But we're in an academic institution, so we have these little things called ethics. And they don't always necessarily let us do that. But what we're saying is before we try and go through a whole ethical review and to all that trouble, maybe we should just talk to a couple people. Now, if they happen to be in our family or our neighbors or something, no problem. We can have informal conversations with them, it's fine. But what happens when you don't have direct access to people like that? How do we engage patients or persons in that kind of research when we don't know who they are?
So this is simply pounding the pavement, okay? You actually have to do some work. Part of it is, can you leverage, again, those that have access to this, okay? Sometimes I've seen a researcher, an innovator, go up to someone who knows nothing of research and innovation, and they're asking this patient, what do you think about this? And they're starting at a very basic level. I think you got to pick and choose. If that's what if you know what you're looking for, again, it's find the lowest hanging fruit. Who out there already wants this research that you think, okay, that in your gut says, okay, I think it is Paul Lee that we want to get, okay, someone like Paul. And if it's not Paul, okay, then that counts as a failure, you move on, okay? But sometimes this is simply a numbers game, okay? It's like I've seen some of you just say, well, I knocked on 2 or 3 doors. And I said, keep going, right? You stop at 2 or 3 doors, and that's not enough. Don't be shy. Hey, if you're shy, well, that's who you are, but I'm challenging you to go out and knock on 30 doors, okay? 30 doors, and just ask, this is exactly what I'm kind of looking for. Can you guide me to this, or do you know someone there? Okay, someone has to know, just you've stopped too early. So that's kind of my view, is like, learn how to pound the pavement, yeah.
I want to jump in here and make a distinction, though, between research, the systematic, formalized approach towards answering a particular question, and exploring and sort of design approach. Researchers don't magically come up with great research questions that they magically somehow mold into protocols. There is a lot of to and fro and investigation and talking to peers and talking to people in communities. So it's a very different thing to say, oh, we're going to run a study with instruments and formalized, as opposed to going and breaking bread and chatting with 1 or 2 people about your experience and, you know, figuring out if what you're doing is actually meaningful. So the other thing, I'm just going to take a little privilege looking at the time, because we want to leave some time to actually talk to one another. I want to go back to this tokenism. And this is something that is a huge, huge concern, both intellectually and in terms of on-the-ground practice. You may remember way back when, in the day when we were designing interfaces and early computing, there was this idea that there is a mythic user, that there is this monolith, like, you know, 2001, where you can look up this one type of user, and everyone in the design space was designing things for the user, and we were all user-centric. And then all of a sudden, people started to realize, wait a minute, no one person necessarily uses software or computers in the same way. To say that there is this one user and design for the user is actually really a bad idea, because there is no such mythical beast as the user. By parallel, I would say there is no one patient. If you have one patient on a pedestal and you're making an archetype out of them, that they speak for everyone else that has a condition that may be in that area or that genome or that particular syndrome, and you're saying they speak for everyone, then you're not really involving patients as partners. You are not actually being person or patient-centric. You are taking a human being and creating an artifice out of them. That is the biggest and worst form of tokenism, where you let one voice become the voice for everyone. And that's not the spirit, I think, of what we're trying to do.
So I would totally agree with that, and I often feel very uncomfortable when I am, quote, the oracle around the table, because I certainly don't feel like one. And it really argues in favor of having a minimum of 2 at the table. The other thing I encourage my colleagues who are patient partners is to suggest other ways to bring voice to the table. So you may have 2 patient partners on a team, but then are there aspects or issues around the research that you want to get more voices to? Should you have workshop or a focus group with a bunch of others who might be able to add their voices. And I've recommended that on a couple of the teams that I've been on. In fact, the 7-year one, I convinced them to have, I said, I'm not going to be the only one. It's an international. And I said, I'm the only one and I'm from Canada. What about people from other places? So we now have a second patient partner who's from Australia, which is wonderful. And I said, you know, be prepared, because we also will need to do focus groups and so on to reach out, because this really does deeply need more public involvement. So I agree with you totally. And I think this is some learnings that we're just starting to really develop about how to move this whole thing to 2.0, if you will, and layering in the different levels of engagement is one way of doing it.
The overall irony in research is good research has significant power, or in qualitative research, it's triangulated. It's not one voice. You are looking at patterns from lots of people. So with that, I would like to thank all of you for starting some really engaging conversation. I think there's a lot more to be had, and I welcome all of you to take the card in your left or right hand pocket and prepare to put stuff in your left hand pocket, because we have some time now to actually, this is the stuff that Ron was talking about, the side conversations, the getting to know one another in the room and with each other, and I really look forward to the smaller group conversations. So thank you, Stacey, and thank you both for coming. I know you're in great demand for your engagement, and I hope that all of you will come and ask them about various experiences and engage.
Just on my part, I haven't come to the first year program yet with donuts. I usually do that, yes. So I'm gonna come, okay, before the end of the year. I always bring Krispy Kreme donuts just during the break and I hang out. So I will be back a few more times, hopefully. Just some of them are looking at me, what is he talking about? But you guys know I always bring donuts.
So thank you very much for the opportunity to have this conversation, and I hope to have more individual conversations shortly.
Thanks so much. It was so nice to meet you both.
Thanks, Stacey.
Thank you, Stacey.